There's a reason that the neurologic exam begins with the mental status, and it's for the same reason that your general medical exam should begin with the vital signs. Is your patient even stable enough for a comprehensive assessment? And for the mental status, is the patient alert enough to participate in the exam? Are they able to comprehend the commands you're giving them, or the information you provide them about their care? Then what happens if you discover an abnormality in the mental status? Altered mentation is the most common reason for a neurology consult in the inpatient setting, and it can be due to a focal brain lesion, such as a stroke. There can be a global cerebral process like hepatic encephalopathy, seizure, or a postictal state, or there could be a toxic ingestion. And a thorough mental status assessment will be instrumental in, first, helping you localize the lesion, and second, reveal that proximate cause of the cognitive disturbance.
All the neurological diseases have a predictable pattern.
We know what pattern that you, as a healthy individual, should fall into.
Every assessment that we use is carefully standardized and normed.
And like we'll get into today, the mental status exam is a critical tool in your neurodiagnostic battery.
I think we're still the gold standard.
Welcome back to Brainwaves, a podcast about neurology and medicine and all the fascinating science and history that come with it. Today, we're taking a deep dive into the mental status assessment, what you need to know as a healthcare provider in evaluating and managing someone who may seem just a little off. I'm Jim Siegler. Stay with us. This week, I'm joined in the studio by Dr. Andrea Casher.
I'm a board-certified neuropsychologist, and I'm the director of the neuropsychology lab at Cooper University Hospital.
And this guy needs no introduction.
Well, I think we have to be in good health. I'll tell you what, this is a very important job, to put it mildly. There's nothing.
I'm playing back this tape from an earlier interview in 2020, not because I want to embarrass Trump, not because I'm anti-Trump. I mean, as a healthcare provider, I'm not alone in that I've been quite disappointed with our current administration, but I only bring up this interview with our president because he really makes an easy target.
And yet I've done more than any president in the first 3 years in history.
And he highlights some very important elements of a mental status exam.
Is that I took a test. I said to the doctor, it was Dr. Ronnie Jackson, I said, is there some kind of a test, an acuity test? And he said there actually is, and he named it, whatever it might be. Because I have like a good memory. The first questions are very easy. The last questions are much more difficult. Like a memory question, you'll go person, woman, man, camera, TV. Could you repeat that? Person, woman, man, camera, TV. If you get it in order, you get extra points. They said nobody gets it in order. It's actually not that easy, but for me it was easy. And that's not an easy question.
Let's break down a typical neuropsychology clinic visit. Walk me through what you typically do on a first encounter.
Well, prior to the first encounter, I'm going to walk you back a step. I have a referral question. I've got a medical history, and I've got a sense of what is going on. What is the referring physician asking me for? Is it a diagnostic clarification? Is it a functional question? Is it clearance for surgery? So I kind of know what I'm getting into. When the patient presents, I'm going to get a very extensive history.
In Dr. Casher's clinic, because she sees a lot of cognitively impaired patients, a lot of patients with neuropsychiatric disease, poor historians, Dr. Casher is going to get a thorough history from the patient's perspective and from the perspective of a reliable historian.
A corroborative source, be it family member, someone else who is noticing, because often you get different point of view.
And this is a requirement for her visits.
It's grist for the mill. It's important to know if you think you're fine and your wife doesn't think you're fine.
So you need this other authority figure, a friend, a family member, who can assist with that clinical history, including
a vocational history and an educational history,
which we'll circle back to in a minute.
During that interview, I'm looking at language. I'm looking at their insight. I'm looking at their ability to stay on topic. And I'm also looking at trying to discern what their baseline is.
Over the course of the evaluation,
More or less an hour interview.
Dr. Casher, sometimes with a graduate student or a resident physician, will determine what the patient's baseline cognitive status is, how much their present state is a deviation from that baseline, and perhaps more importantly, what to do about it next.
I mean, often there's a question about return to work.
If the patient is a high-level executive or a financial consultant, and they're having trouble remembering critical tasks,
Return to school.
consider a student who's had a concussion and still having trouble maintaining attention.
Driving.
Maybe the executive chef is mixing up ingredients or forgetting how much they put into a particular dish. Recognizing these early signs, providing early counsel, and offering targeted treatments like a cholinesterase inhibitor or speech therapy for the salesman with aphasia, this is what clinicians like Dr. Casher do. Most of the listeners in the audience have done a mental status exam, but let's review the most high-yield domains of cognitive assessment, how to test for them. Why are we doing this dedicated comprehensive mental status assessment?
Yeah, that's a tall order to talk about all those things at once. I think if you liken this to sort of the foundation and the framing and the finishing of a building, it's helpful to think about it in that way. So if you're talking about attention and arousal, those are kind of the foundation, the basement. Then you're looking at a higher order kinds of skills, language, visual spatial skills, executive functions. Basically, what you're doing is getting a sort of moment in time with this patient.
Assessing the mental status is a fundamental part of the neurologic exam. Like Dr. Casher said, it is the foundation of the building you're trying to construct. Without knowing the patient's level of alertness or attention, their ability to understand and follow commands, you can't really proceed with your comprehensive evaluation. Someone who has visuospatial neglect, for example, may not be using their left arm, and not because of weakness, but because of preferential orienting to the right side of their visual world, which is what we think happens in spatial neglect. It might appear that their left arm is weak, but it's really just that the patient is unintentionally failing to utilize it, and you should know this before you proceed with the power assessment of that arm.
So that's what you're trying to do with the mental status exam, is to gather as much behavior from as many different domains as you can. But again,
more specifically, these domains include alertness. Does the patient awaken appropriately, or do they require some sort of stimulus? Attention. Can they maintain fixation on you, or are they easily distracted? If you give them a simple task, show me 2 fingers, count backward from 100. Can they do this?
That's not an easy question.
Do they have fluent speech?
Fake Russia, Ukraine. I mean,
Can they comprehend complex language? Show me your thumb after you blink twice.
okay, that's very good.
Can they repeat a phrase? Traffic conditions are expected to be heavy.
If you get it in order, you get extra points.
Is reading or writing a problem? Orientation. What is their insight? The year, the month, their location. Why they're being examined by you in the first place.
So, for example,
Memory.
Does I have like a good memory?
Can they recall a good history for you?
You're really not able to assess a whole lot of other things if the person is.
Do they know recent events? Who's the next president? Can they register and encode information and delayed recall? Or do they need prompting?
You can't assess
Fund of knowledge. How aware of their circumstances are they?
Winning Pennsylvania.
We have won Georgia.
Frankly, we did win this election.
Visuospatial processing. Again, this brings us back to neglect. Are they aware of their visual or spatial environment? If they're asked to bisect a horizontal line, do they identify the middle of that line? Do they extinguish visual or tactile information with double simultaneous stimulation? And executive function, organization of knowledge, abstract thinking, perseveration, and inhibition.
You want to build the building to find out, are there cracks in the foundation? Do you need a new roof? Where are the problems? And at what level are you dealing with a fundamental problem? So, for example, if the patient is attentionally impaired, you're really not able to assess a whole lot of other things if the person isn't able to engage with you and to follow commands. And you can't assess comprehension the person's ability to understand language if the person is too attentionally impaired to even hear what you said. So you're kind of determining where in the system, in the plan, the architectural plan, your problems lie. In a lot of outpatient neurology, the question is anything wrong with this person? We get a lot of folks who come in with subjective memory complaints, and they're a little anxious and basically fine.
And it's so difficult whether you're in the outpatient setting or the inpatient setting, because often, unless you're first evaluated by a neurologist, the consult or the referral is for an altered mental status, which really doesn't mean anything other than something is different about this patient's behavior. Mm-hmm. And what that means, whether it's due to a stroke, whether it's due to inflammation in the brain, whether it's due to seizure, you really need to dive deeper into that mental state to figure out where the problem is, where the crack in the foundation is. Can you really get to the penthouse? Can you really even start to physically examine the patient? You won't be able to do that until you have a sense, are they able to attend to me during the exam? Can they comprehend what I'm telling them to do? Next, I wanted to talk about the Mmse, or the mini mental status exam, kind of as an example of a semi-comprehensive mental status assessment. What is the Mmse used for?
I think it's used to get a gross evaluation of mental status, i.e. cognition. But I don't think so many people are using it anymore, or if they're using it, they're augmenting it with other things, with a clock drawing, with more attenuated measure of attention. I prefer the MoCA.
Is Montreal Cognitive Assessment, MoCA.
I think the MoCA is fine as a bedside eval or in-office eval for neurologists. My issues with the MoCA have to do with how it's administered.
You'll need to know which items can be repeated and how questions should be phrased, because this is important for some of the items.
And I often get MoCAs from the referring neurologists that could give you a lot more information than they get from the MoCA, and how they're scored, because the MoCA has norms, actually, and you can compare a person's performance on the MoCA. So if I have a guy who's got a PhD in geology and he's 55 years old and he gets a 25 out of 30 on the MoCA, that's not a great score. But if you're using a 25 cutoff, someone might regard that as a fine score. On the other hand, if I get someone, I had a woman the other day with a high school education, and she was, in her 80s and unskilled laborer, and she got a 19 or 16 maybe on the MoCA, and that's actually not bad.
Just to rewind a bit, the MoCA, as you may know, the Montreal Cognitive Assessment, is a 30-point neurocognitive test that was developed in 1996, and it tests a pretty broad range of cognitive functions. It starts with visuospatial assessments and a clock drawing. It tests for orientation, working memory with serial subtraction and digit span testing. It tests for executive function using oral trails and verbal abstraction. How are a watch and a ruler alike? There's a 5-point delayed recall component.
Woman, man, camera, TV.
It tests for naming, repetition, and the total score is used as a simplified threshold as to whether the patient is abnormal or cognitively normal. But each item should still be considered separately. Important to note is that hard cutoffs for tests like the MoCA should not be applied to all patients, like Dr. Casher said. A 55-year-old geologist with a PhD who scored 25 might indicate cognitive impairment, while an 80-year-old with a high school education who scored a 19, that could be perfectly fine. In a 2011 paper published in Neurology, Drs. Rossetti and colleagues validated the normative ranges for MoCA in a diverse population. The original MoCA score, and the normal range for it, was derived using a homogeneous population of healthy Canadians, so the thought was that the normal range of 26 to 30 may not apply to everybody. In their study, Rossetti found that blacks and Hispanics scored significantly lower when compared to white counterparts, with significant differences observed according to the total number of years in school. In response to these findings, the original authors of the MoCA score argued that the population that was studied by Rossetti and colleagues may have included patients who had mild cognitive impairment, and their patients were therefore not representative of cognitively normal individuals. Therefore, a MoCA score of 23, which was the mean score among Hispanics, would be suggestive of cognitive dysfunction. Rossetti and colleagues dispute that notion, and the normative ranges that are based on age, sex, ethnicity, and educational level, they remain highly controversial. Regardless, MoCA scores should absolutely be normalized to the patient's educational background, which is why somebody who has 12 years of schooling or less will get a bonus point to their final score.
So things on the MoCA, for example, where you have to do serial 7 subtractions, subtract 7 from 100 and keep subtracting from each remainder. Well, here's the secret. The base rate for that, the number of normal people who can perform that task accurately, perform 5 accurate subtractions in the population, the number of normal people is somewhat low.
Low as in 70 to 80% of older people can successfully subtract 7 5 times.
So if you get people on a MoCA who lose points, 3 points for the serial 7s, that's not necessarily meaningful if they're someone who could never do math.
What are some other limitations of these kind of simplified tools for assessing the mental status?
Again, the degree to which they're used properly is important. On the retention trial for the MoCA, you have to learn 5 words, and then a few minutes later, tell me those words. And if the person can't freely respond to that prompt, then you give them cues. One of them was a part of the body. One of them was a type of fabric. And then finally, you give them a multiple choice trial. So a lot of times the neurologists skip those. That could be the difference between a vascular disorder and an Alzheimer's disorder.
This is an important point. If the patient is not able to recall the information with cueing, you give them a hint or a selection of options, and it still doesn't ring a bell, that patient truly cannot register and recall information due to cortical dysfunction. But if you give them a hint, and they eventually remember the word,
that indicates that it might be a vascular issue. The information is not wiped from the slate. It's retrievable, but the person can't spontaneously retrieve it.
Another limitation of the MoCA is that the entire test is not timed. There's one part of the test where the patient says as many words as they can beginning with the letter F in just under 1 minute. But somebody who takes 2 to 3 minutes to copy a cube or draw a clock, that could indicate significant subcortical dysfunction. And the result of the MoCA, a number, really does not communicate what, if any, cognitive impairment the patient may have. A patient with an isolated memory loss may score 25 and be technically fine.
When you ask someone, how are a dog and a lion alike, and it's just a check mark, that doesn't tell me if the person said they have fur, they have 4 legs, they're animals. So there's a difference between a concrete and an abstract response. And there's a lot of qualitative information that I think can be gleaned from these tests. But if you're only checking things off on the MoCA, you're going to lose that.
I love that point. I think it's such a great point because I also emphasize that to residents when we talk about the stroke scale, that it's not just about an absolute number that tells you the most critical pieces of information. You know, somebody could have a stroke scale that's very low, but it could be a cortical finding. So something that would suggest a large vessel occlusion or proximal stenosis or occlusion, something embolic. But for the MoCA, the Mmse, it's not just that you need to know the score to give you a sense of something potentially abnormal or normal. You want to know like what specifically is wrong with that person.
And I think the clock drawing on the MoCA is going to give you a lot of information. The clock's a great test and has a great history in neuropsychology and neurology. Think about it. Think about what you're measuring there. You're not just measuring constructional skills. That's one thing. You're measuring spatial planning, which is kind of an executive task. You're measuring the person's ability to translate the time. It's an abstraction, 10 after 11. So how many times do you get clock hands that are pointing to 10 and 11? You might see a neglect on a clock. That's a very important factor. It's looking at parietal lobe functions. It's looking at frontal lobe functions. It's looking at micrographia might show up on a clock. I mean, there's a wealth of information that you can get from very simple tests.
Returning to the limitations of your mental status assessment, particularly with the MoCA, language and culture play a significant role. Maybe your patient has never seen a rhino or a camel. Maybe your non-native English speaker has never used the words velvet or daisy. So how are they supposed to remember it during that memory assessment?
It's extremely complicated, and it's a hot topic these days because I think people inadvertently penalize people for not being native speakers. And the question of what is culturally based, things like block duplication, goes beyond language too. I mean, there are many things. We sometimes see migrant workers who haven't got much formal education, and you give them red and white blocks to put together, and it's supposed to be a novel task, but in this case, it's like beyond the universe of novel. So I think you make do. Ideally, you have an interpreter. Ideally, you have people who have multiple languages. I've done Korean MoCA once.
And just to interrupt, if you don't have a MoCA in the patient's specific language, you'll need someone to interpret the test for them. Somebody ideally other than the patient's friend or family member.
As you're saying, a neutral interpreter, not a family member. Because, yeah, it's human nature. If it were my dad, I'd probably want to slip him a few answers on the memory testing.
Something else stands out to Dr. Casher during her assessments of a patient's cognitive function. We rely so heavily on language and a verbal history from the patient, but there's more to the patient's mental history than words can capture.
I think the behavioral piece is enormous. And again, there's so much grist for the mill when someone is sitting across from you. It's not just what comes out of their mouth and how they answer your questions. It's how quickly they answer your questions. There's your bradyphrenia. Do they interrupt?
As in, is there executive dysfunction or disinhibition, which we see in early Alzheimer's dementia and frontotemporal dementia, and these typically occur with disturbances in both short and long-term memory retrieval.
Do they lose their train of thought?
A feature of inattentiveness, which can be etiologically nonspecific. Maybe it's related to toxic or metabolic encephalopathy or autism, and a variety of dementia syndromes.
When they go to the bathroom, can they find their way back?
Is their visuospatial processing impaired? We see this in patients with dementia with Lewy bodies. Or if it is a memory problem, like the patient can't register and recall parts of their environment, is it a disturbance of mesial temporal lobe function?
I had a patient, I think it was a bus driver actually, who came back into the office after he had left and said, "Oh, I forgot my bag," and grabbed my briefcase and started to walk out of the office with it. So the behavior, agitation, you get people who have no frustration tolerance, and that can be seen in the evaluation or in the testing. Insight, which was already mentioned. That's important to know that person doesn't think that he or she is fine. And that's typically not correctable. It's pretty hard to help people with insight. That's a part of a neurodegenerative process in a lot of cases.
And there's more to the body language and actions, or inactions, than what you might incidentally notice. Some things you'll specifically test for, like praxis.
When you give them a pencil, do they grip it oddly? Do they look at the blocks and are not sure what to do with them? Do they have a lot of trouble putting pegs into a board?
Which might indicate cortical parietal lobe dysfunction, as in a patient who has Alzheimer's disease or a prior large stroke. So there's some features of the mental status that help you to localize the lesion, or when the lesion is more distributed, the patient has a tauopathy or other degenerative process. Some of these features are suggestive or even diagnostic of a neurologic condition.
Certainly. I mean, the salesman, for example, who had preserved executive functions, pretty much preserved visual memory and nice visual spatial skills, but had anomia to beat the band when you showed him pictures of objects. The naming skills and the fluency skills were below the second percentile. What are my diagnostic possibilities here? And that's when one goes through the sort of decision-making and rollouts. He didn't have a stroke. It's not at this point an Alzheimer's process. He's got too many preserved skills. You can have naming and something else and functional difficulties and think about a cortical dementia, but that's not what I'm looking at.
If you didn't guess it, Dr. Casher's patient has primary progressive aphasia, a tauopathy with frontal and temporal lobe degeneration, sometimes inherited as an autosomal dominant condition due to mutations in progranulin, or the GRIN gene. And the condition is defined by its lack of memory impairment, visuospatial abilities, and behavioral disturbances, an isolated progressive language deficit. And this salesman met those clinical criteria, which were established by a consensus working group in 2011. For this reason, and for many others, the mental status exam is often diagnostic in itself. Imaging can be suggestive, or even consistent with your clinical suspicion, but you need to have that clinical suspicion first.
I think we're still the gold standard. So again, back to the salesman who had no findings on CT scan or MRI, that I think we're able to discern difficulties that may not show up on neuroimaging and quantify them. Also, again, look at a person's skills in comparison to their hypothetical baseline in an objective, scientific way.
Many parts of the mental status exam can be quantitated.
So it's not guesswork. No offense, neurologists, that, when you're doing bedside testing and, this is okay and this is not okay, we're gathering enough of a behavioral sample to very carefully come up with a pattern that may match a known pattern for a neurological disease or difficulty, or not, or we can rule it out.
Rule it out, as in tell a patient, you think your memory's failing, but really you exhibit a lot of anxious tendencies.
You're a little anxious.
And you exhibit signs of inattention. Your memory is actually quite good. Or you might say,
this is what 62 looks like.
It's not Alzheimer's. And I'm really glad to tell you that it's probably not going to get much worse than this.
And the problems, those subjective complaints that you have are not abnormal.
And again, this is not guesswork.
All the data is, again, every assessment that we use is carefully standardized and normed, and we know what's normal. And we know what's normal for you, and we know what's normal for an 80-year-old with 16 years of education versus 8 years of education. And, what's normal for me is going to be different than what's normal for my husband. All the neurological diseases have a predictable pattern, all the ones that involve cognition, and you can make some matches and or hypotheses with some degree of certainty.
And that's all we got for you this week on the Brainwaves podcast. As always, thanks for checking out our program. If you enjoyed what you heard this week, you might like some of our prior shows like episode 145, Astroglia and Alzheimer's disease, or episode 111 on the interplay between depression and dementia. As a reminder, Brainwaves is intended for medical education only and should not be used for routine clinical decision making. This week's episode of Brainwaves was produced by myself, Jim Siegler, with the help of Dr. Andrea Casher out of Studio 3 in Philadelphia, Pennsylvania. Music for our program was courtesy of Unheard Music Concepts, Purple Planet Music, Lee Rosevere, and Scott Holmes under a Creative Commons license. Our theme song was composed by Jimothy Dalton. Sound effects by Mike Koenig and Daniel Simeone. For more information on what was discussed in the show, as always, please take a look at our show notes for the references, and follow us on Twitter at Brainwaves Audio. I'm Jim Siegler. Talk to you soon.
That's amazing. How did you do that? Very few people can do that. Very few people get that. You understand. It's not